So hello and welcome to the inaugural IIOP podcast. So the Irish Institute of Pharmacy, as you probably know, is the body which is responsible for the continuing professional development for pharmacy professionals and also for supporting the development of the pharmacy profession. And we do that with an ethos of supporting, enabling and trying to find synergies within the profession. And we really have a vision for pharmacists individually and collectively to be able to realise their potential in creating and contributing to a healthier Ireland. So today we've taken a bit of a different approach to our work, and we are engaging in a podcast of discussion which builds on a masterclass that was held yesterday in the Royal College of Surgeons in Ireland. So that masterclass was organised by three bodies: the East Tennessee State University, the Royal College of Surgeons School of Pharmacy and the Irish Institute of Pharmacy, which is based in the Royal College of Surgeons in Ireland. That masterclass focused on how can we help the transition to team-based healthcare. And it was a great opportunity to hear from colleagues in East Tennessee and from Irish colleagues about how we can move towards greater interprofessional collaboration. In order to build on that, we thought what we'd do is we would have a conversation today that really focused on the practicalities of interprofessional collaboration, and that we would bring some of our colleagues from East Tennessee University and some of our practitioner colleagues here in Ireland and have a good discussion about how we can move towards interprofessional collaboration or team-based care, what it is, what some of the challenges might be and what the benefits would be to doing that. So I'm joined in studio today by a very eminent panel of people. And I'll introduce them by name first so that you know who's in the room, and then I'll ask each of them to give a brief introduction themselves so that you can understand more about their background. And following that, we'll start a discussion really, just informally talking about how we can embark on the journey towards interprofessional collaboration, or indeed maybe we're already on the journey and hearing about instances where that's the case. So we have with us Dr. Reid Blackwelder, Dr. Bryan Cross and Dr. McKenzie Calhoun from East Tennessee State University. And we also have Paddy Byrne, who is from Byrne's Pharmacy in Ballsbridge, Dr. Kieran O'Driscoll, who's a neuropsychiatrist who works in Bloomfield Nursing Home, and then myself, Catriona Bradley. I'm the Executive Director of the Irish Institute of Pharmacy, and my role here today will just be to facilitate a conversation amongst the colleagues that are here with me in the studio today. So maybe by way of introduction, if I go to our East Tennessee State University colleagues first. And Dr. Reid Blackwelder, would you like to introduce yourself and just tell us a little about who you are and where you're from?
Certainly. I'm a professor of family medicine, so general practitioner at ETSU. I've been there since 1992. I'm also the interim chair of our Department of Family Medicine, which oversees training in the specialty of family medicine, and I get to work directly with medical students. I've also been involved with interprofessional work since I got there in 1992. As an aside, I'm past president of the American Academy of Family Physicians, which is our national member organization. And during that time, I was able to be a part of a large push of our organization to truly recognize the value and importance of team-based care and to move that forward at a national level.
Fabulous. Thank you. And Dr. Bryan Cross.
Good afternoon. My name is Bryan Cross. I've been a pharmacist who's been embedded in various different kinds of primary care offices for probably the last 25 years now. I have a BS and a PharmD degree. I did 2 residencies. The second one was in primary care, and have been involved with interprofessional practice and education, and most recently took a position at our university as the director of interprofessional education.
Fantastic, thank you. And then our third visitor from East Tennessee State University is Dr. McKenzie Calhoun. Welcome, McKenzie. Can you tell us about your role?
Certainly. Thank you for having us. I am a little bit newer to the game than my other colleagues from East Tennessee State University, in that I graduated with my Doctor of Pharmacy degree from ETSU in 2011 before completing 2 residencies, the first in pharmacy practice for the Veterans Affairs Tennessee Valley Healthcare System, which takes care of our veterans in Middle Tennessee, and then completed a second residency in ambulatory care, which is somewhat our version of primary care. for pharmacy in America, and with a strong emphasis in family medicine and in academia. And at that point, I joined the faculty. Other than Dr. Cross, I am the other pharmacist faculty member in our IPE program, our Interprofessional Education program, that's currently in its second iteration at ETSU. And so I also am a clinical pharmacist, meaning I work in one of the family medicine practices that Reid is responsible for. And so I work with 18 resident physicians and 6 faculty attending physicians, as well as a social worker and a clinical psychologist and a nursing staff too. So I get to practice and play in this area all the time.
Fantastic, thank you. So those are the 3 colleagues who are joining us from East Tennessee State University, and it's clear that from the masterclass yesterday that your real focus is on team-based care and looking at how we can get greater collaboration between the different professions in patient care. Joining us today, in addition to our East Tennessee colleagues, are 2 Irish professionals. So, Paddy, if you'd like to introduce yourself first, because you're already working in this area in interprofessional collaboration in Ireland, but maybe you can just give us an overview to your background and what you're doing currently.
Well, I've been a community pharmacist based in Dublin for the last 25 years, and as part of that I was supplying what was a very small, quiet, long-term psychiatric unit, which was originally based in Donnybrook, but it moved in 2004 and has now morphed into a 122-bed psychiatric hospital. And I've had to grow with that, and I have done my diploma in psychiatric therapeutics, and about 4 years ago I started to develop a clinical role, which has mushroomed for me, and it's been very good and very productive. So I'm no longer the person who just drops boxes in the middle of the night. I'm involved clinically on a day-to-day basis within the hospital.
Okay, thank you very much. And then finally, Dr. Kieran O'Driscoll. Kieran, if you could introduce yourself.
Yes, I qualified in Ireland and then I moved to the UK. So I've worked in the National Health Service in the UK all my adult life, eventually ending up in the northwest of England as a neuropsychiatrist in Manchester Neurosciences and Liverpool Neurosciences unit. And I've recently returned to Ireland and I'm working in Bloomfield Hospital and the National Rehabilitation Hospital currently.
Fantastic. So it sounds like we have the right people in the studio to be talking about interprofessional collaboration. But maybe before we start on it, it would be good to just recap on some of what was discussed yesterday, because what we had there was a masterclass being provided by Dr. Reid and Dr. Bryan about what is interprofessional care or team-based care. So maybe to start off, so that we're all clear about what we're talking about, I can go to both of you with a recap or synopsis of what you discussed yesterday about what it is we're actually talking about. So, Bryan, if you'd like to start.
Sure, thank you. I think at its heart, the idea is the patient is at the center, and the fact that it's called team-based means that there is a group of practitioners, providers, professionals that are coming together for a common goal of improving the health and welfare of that person. Bringing together various backgrounds, various trainings, removing egos at the door, and making sure that that they are focused on the improvement of that person's care, whether that is related to cost, whether that is related to quality, whether that is related to bad things happening, that as multiple eyes are taking a look at this patient, that they're going to look at them from different angles. And if we can approach this with good communication and with the center being the patient, then we believe that outcomes as well as costs will both be improved.
Fantastic. So really what I'm hearing there is the patient at the centre of it and using all the different skills from different professionals to basically put the best medical care into effect.
Absolutely.
Okay. And so, Reid, how have you come to this, or what's your perspective on it from a family practitioner perspective?
I think a very critical aspect of this is to ask the why. you should do this. And certainly in our country, we deal with a true challenge in that our outcomes for our patients are not very good, even though we spend more than any other country per capita. In addition, our patients as well as our providers are not satisfied with the way that healthcare is provided, and I put that in quotes because our system is not much about health, not very caring, and not really much of a system. So that's the why that we realized we had to do something different and go outside the norm. It's important, too, that especially at East Tennessee State University, we are developing some practice examples, so real-time interprofessional, interdisciplinary approaches to improving the care of our patients. At the same time, we are developing educational processes. And I really appreciate your emphasis here in Ireland on interprofessional learning, because that's very different than just education, because we see it's critical that you can't just sit people in a room and listen to a lecture and count that you really must have ways of engaging folks from different disciplines at that basic level so you truly get learning and transformation.
Okay, and can I ask, in your experience as a family physician, how has it manifested itself in your practice, or how did it come about that you were collaborating? Was that something that the American system allowed for, or was it something you had to create yourself?
A little of both. We do have, I direct 3 residencies now, but when I first came there in 1992, I joined a residency, and at that time, that residency had an embedded psychologist and social worker. We were blessed over time to get the College of Pharmacy, and so we also made sure that we added a pharmacy faculty. And then because I was sort of on my own at a outlying clinic, I didn't wait for a memo or permission, and we started to do some creative things in terms of interacting about our patients and trying hard to see how we could change the way we delivered care. Where we are now is some truly integrative models where patients will come in and the focal point is the patient and their need. For example, someone who's just left the hospital who'll come back in, which is required by our insurance payers. So we've arranged to make sure they come in. And then our social worker, our pharmacist, our psychologist, and importantly, our learners will also be engaged early on. So it's really a way of becoming, to use a term we were talking about at lunch, proactive in a reactive situation. And we have, just as one example, we decreased our readmission rate for certain conditions from the 30% range to about 12%. Which is a very dramatic change in a relatively short time. And that success has allowed us to build in some other processes, and we have some exciting things that we're working on.
Fantastic. So there's real evidence for this working. Before I move to our Irish colleagues, can I ask, bringing you back to those early days, you said, you were on your own in a small practice potentially. How did that interaction start? Or what were the things that you needed to do when you were reaching out to your colleagues around you?
There were probably 2 aspects. One was, and I'm not sure the history of how it happened, but our Department of Family Medicine was set up differently than some of the other clinical departments. We had a state mandate as a medical school and a training program to graduate the primary care providers that our region needed. And therefore, our funding setup was a little bit different. And so coming into a situation where I actually had interdisciplinary providers meant I had an opportunity. You could either just say, okay, we're all in the same office. That's nice. That's your office. This is mine. Or you could actually begin to work together. And so we started to make sure we communicated, understood roles. We laid the groundwork for a lot of the interprofessional work that we're doing right now. And then as another part of that, our institution had received a grant from the U.S. government in 1991, about the time I got there, that allowed us to put a great deal of money into interprofessional training. And through that model, we created a communications course which had students from all different branches come together to actually begin to learn how to be respectful of each other, to understand the roles. And over the past several decades, we've built on that, and that has actually created the foundation for what Bryan and McKenzie are a major part of in terms of a much broader approach to how we can communicate respectfully at the professional level, which allows us to do much better care of our patients.
Okay, fantastic. Thank you. Moving to the Irish setting then, it'd be interesting to hear from Paddy and Kieran as to how they view interprofessional learning or how it's manifest itself in their practice. So I don't know who would like to start, or if you'd like to do an introduction to it. Paddy, perhaps you can give us an overview of how you two work together, or is it even a wider team than just the two of you?
Well, that's the thing, Catriona, is that we would meet every Tuesday, and we would meet as a full team. So there's Kieran's the neuropsychiatrist, there's GP, pharmacy, clinical nurse manager, physiotherapy, occupational therapy, social worker, all sitting around a table. And the interesting thing is the patient is invited to that meeting. And initially, patients would actually find it quite daunting to walk in and find 10 people sitting around a table. But then you actually see the patient actually liking the idea that these people are taking the time out of their day to sit down and just focus on them as the patient and what their care looks like. Or if it's not the patient, it's their patient's relative. So thankfully, we've got one bit right, and I learned that yesterday, that we have the patient at the centre of our model. And it gives us an opportunity that we're all sitting there as a team. Pharmacotherapy is one part of it, but it's only one part of it. But it does allow us to do a structured medication review, and where are we going? And Dr. O'Driscoll would always introduce the patient as the diagnosis first, because sometimes you actually forget what the original diagnosis can be when patients are in long-term care for that long, and what's our aims and what's our treatment. So it does work very effectively, and it's great to be part of it.
Wow, that sounds like a fantastic model. Kieran, you're involved in this as well. From your perspective, how does it work?
Well, my earliest experience of multidisciplinary working was really through rehabilitation, brain injury rehabilitation. And that was because there were so many problems which covered a number of different specialities. As Paddy was saying, physio, OT, neuropsychology, neuropsychiatry, neurology, and all of those specialities would be sitting around the table contributing. What I noticed was that there was a sharing and a growth of knowledge across the different specialities, because you could actually listen to your fellow colleagues' thinking and the formulations, and it was a privilege to learn over the years about the different specialities and their contribution. And then I was flying back to the neurobehavioural clinic in the National Rehabilitation Hospital in Dublin once a month, where the interview was actually conducted by a neurologist in rehabilitation, a neuropsychologist, and myself. So that was three specialities conducting the interview, which again was an extraordinary experience because of the learning from your colleagues on the hoof, so to speak. What has been interesting in Bloomfield is that it's my first unique experience of having a pharmacist present, which is an extraordinary privilege because Paddy's my previous experience of pharmacy is that they were very good at responding to a closed question, but that was usually at a distance from the actual clinical heat of the moment, and you got your answer an hour later. So what Paddy contributes, which is unique, is that he's actually part of the team in the clinical discussion. And is there discussing the pros and cons and making spontaneous recommendations as to what might or might not work, which is an extra dimension to the contribution from pharmacy to my previous clinical experience, and one which is invaluable.
Okay, and Paddy, how did you end up in this team? Was there a special invite given to you, or did you elbow your way in, or how did that come about?
I didn't wait for the memo.
Okay.
There was actually an invitation from a locum consultant psychiatrist, because it was suddenly realised that I was the one with the historical knowledge of all the patients, and I was invited in, and very quickly I suddenly developed a role within the group, and you know, at this stage it would now literally pass around the table table with various aspects, and the Cardex is shoved over to me and it's going, right, Paddy, what's the story with the meds? And I will generally have worked up the patient in advance. So I will have a list of things that I want addressed at some stage. In terms of our biggest problem is generally polypharmacy. We have lots of patients who are well over 65 who are on greater than 5 meds. If it was only less than 10, we'd be doing well. So there's a lot of work to be done, and we keep on chipping away at it. So it is interesting. But what we do find, and I have found, is that also when you have family members present or the patient themselves, and you do want to make a change in a regime, there can often be reluctance amongst family members, particularly with the example of the cholinesterase inhibitor for the parent who is now suddenly got a mini mental score that's in single digits. It's no longer clinically indicated, but the family are vested in the fact that mum or dad is still on the memory tablets, they must still be okay. And it's when the group is sitting around explaining to the family that actually the potential side effects could actually be worse for the patient, and the patient can't explain to us whether or not they're suffering from those side effects and express it meaningfully to us, that the family realise actually, it is time to actually stop the Denezapil or whatever it is. So there is an advantage from the team being able to deliver those messages to families rather than an individual having to carry the burden on their own. I think it's a sharing.
Wow. So from a pharmacist's perspective, it's much easier to have those conversations with a patient or their carers when you know that it's part of a team approach.
A team approach, yeah.
Brilliant. And can I ask, though, Kieran, could you not have done that without a pharmacist? Maybe a little bit controversial, but...
It's nice to have your hand held by the pharmacist. Gives you an extra bit of confidence.
I've never held your hand, Kieran. To clarify.
It also, I think, emboldens you. It makes you more proactive. There's a tendency to react and do the minimum in changing the pharmacology, and there's a tendency to leave sleeping dogs lie. But with Paddy's presence, I've found that there's much more of an opportunity to look at the big picture and see whether, in fact, we're not just leaving things because it's easier to do so.
Okay, so there may be a tendency, if the pharmacist isn't there, to not take up the stone and see what's underneath it sometimes. Okay. Yeah. Reid, you wanted to come in?
Yeah, there's a really important point here as well, Paddy, because I think it's easy for us to make assumptions as professionals on the same team that we all agree. And when you have a group discussion about something like a medication change, it's a way of identifying if there might be a team member who actually shares the parents' or the patient's perspective. Because one of the keys for taking care of patients, especially over time, is that we all need to be somewhat on the same page. And if we're not, to be able to have a conversation about that disagreement. Because that is one of the things that I see in the U.S. healthcare system, is that the physician might do X, the pharmacist might give an impression when the prescription is picked up at Y, and then the nurse they see at the health department may have a totally different perspective, and none of us talk, and the patients end up in the middle being totally confused. So your system allows a really great amount of communication at every important level, and it doesn't mean you all have to agree, but you know where you're coming from.
Mm-hmm.
Yeah, and I'm wondering, why does it not happen everywhere? If it's such a great system, if it's good for the patients, if it's good for the colleagues because they're emboldened and they feel comfortable having those conversations, why is this not happening in every organisation?
They don't have Paddy's energy. And
Okay, so Kieran, you're saying is this something personal, that Paddy has a magic formula?
Well, I think Paddy has a magic formula in as much as that he's so clinically knowledgeable. That's the difference. My experience so far with the pharmacology departments is they're superb at giving you the details on the pharmacological level, but Paddy gives you the extra dimension of the clinical discussion. And it means that, as you were saying, that when you're considering doing something, it's out in the open and debated, and the pros and cons are weighed up, and you can find yourself completely changing your mind and doing the exact opposite. And that's what the advantage of the truly multidisciplinary forum adds.
I think, Catriona, I have to point out that I think all pharmacists have the knowledge And it's not just unique to me. I think everybody has it. I think lots of pharmacists have lots of different questions that they're asking themselves constantly as they fill these multiple prescriptions for people every month, but they never get the actual opportunity to ask them. We all have those contacts with GPs in our practices and very good interactions, but they're corridor conversations or quick telephone calls about one specific issue. You're not actually doing a structured medication review, and that's what's different about this. All those little questions that have been niggling at the back of your mind for years as you fill the same 12 items into a bag for a patient, and you're asking yourself why, you get an opportunity to sit down and discuss with a team the whys. And it's always about that question: why are we doing this?
Okay.
And is there another way? And that's the opportunity that arises now for pharmacy and general practice to actually sit down and actually look at structured medication reviews.
Okay. So McKenzie, can I bring you in there, because you work in a similar type of way, I believe, in your setting. So can you tell us a little bit about your experience as a pharmacist working? Is it similar to what the gentlemen here have described, or are there differences?
Oh, yes and no. I function in several different ways within our practice, and I have 2 set clinic days, and the first of those we call it pharmacy clinic, but it is not just a pharmacist. It is always, at minimum, a physician and a pharmacist working together. Typically, we have lots of learners as well. So it one set day a week that's set aside where we know that there's going to be a physician, pharmacist, and then usually resident and or students, both medicine and pharmacy, and sometimes psychiatry and other learners. And the patients that are scheduled within that clinic are some of the same patients that Paddy was describing. Polypharmacy is a big problem everywhere. I think that's not something unique to us or you, and that we have patients where there's, printing off their medication list, it takes 2 pages to just describe all their medications. So sometimes it's that we just need to go through a patient's pharmacotherapy regimen and say, let's look at this let's take a step back and look at it from a broader view. So sometimes it's going through polypharmacy. Sometimes it's INR monitoring, so anticoagulation monitoring. Sometimes other drug therapeutic levels needed. We'll get kind of scheduled in that because that also provides an opportunity for me to do some teaching of our resident physicians too about drug monitoring and management, as well as a lot of diabetes, insulin pump management, and adjustments and things like that. The second set day I have in clinic per week is a transitional care clinic that Reid alluded to earlier, and that was actually one of our residents' ideas. And I always mention that because it was one of our resident physicians several years ago that said, can we do an advanced pharm clinic day where we bring our most complicated patients and we have all these people that we can sit and talk and we can have the pharmacist right there and go through all these things. And we figured out at about the same time that the patients that he was describing that he was primary care physician for were the same patients that we were seeing on our hospital service really often. And they're sometimes described as high utilizers, and that we see them on our hospital service and then as well as in clinic often. So we started scheduling them into pharmacy clinic almost immediately as soon as they got out of the hospital. And so we call it IPTC, which stands for Interprofessional Transitions of Care Clinic, or TCC, Transitions of Care Clinic. And that's been a really great, I think, way that you can see what it is that we've been talking about over the past 2 days, where we sit down in the morning and have our social worker who has already contacted the patient since they've been discharged, plus pharmacy students, residents, myself, which have already worked up the patients, kind of come in with our list of here's some medication-related problems or potentially inappropriate prescriptions, other monitoring that we may need to be doing on new prescriptions from the hospital, things like that. And then the physician, medical students and physician residents and attending physicians at times too that have already looked through the patients as well. And we sit and we conference on the patients and do that kind of getting the whole team on the same page and kind of talking about what potential problems we may have or things that we may need to address. And then we see them as a team. And something that I think is really important is that the patients like it. And as Kieran and Paddy described, that maybe the first time that their patients came in and saw a big team, that it was a little bit intimidating, or the family members. And we kind of worried about that too, of what are patients going to think about having several people involved. And what we surveyed them, and we knew that anecdotally the patients liked the attention. That's kind of what they described as, I'm feeling like a celebrity today, with one person after another kind of coming in and all of us coming in at the end and doing the education together. And so we surveyed them and we got nothing but positive response, strong positive response. And so I think that was also very telling. And then in addition to that, it's the drug information, but I really loved how Kieran described it as it's not just calling a pharmacist and saying, here's a question and getting a black or white answer in a more closed-ended way. But I'm a drug information resource for our team in the context of a patient. And so typically the resident or attending physician or whoever is our psychologist or social worker, whoever is seeing the patient will come and sit beside me and say, I've got Mr. So-and-so who is a 74-year-old gentleman who has this, and this problems and on this, and this medication, and we have these labs. And so it is in that clinical context of I get a picture of this patient. A lot of times we'll go talk to the patient as well. So that is the kind of, in general, I wear lots of hats, but those are a few of them.
Fantastic. So it sounds like you have a great structure. Reid, you wanted to come in?
I have to give a shout out because what she's describing isn't nearly the full scope, and it relates a lot to what you were describing, Paddy. By having everybody face-to-face, getting to know each other, developing relationships, it changes how we can care for patients even when you just need that one question. So it just last week, I'm in my office in Johnson City. A patient reaches out using new technology, our electronic portal, and some other means of reaching with a very important question. She's one of our, I don't know if you have the term heart sync patients, those who just have so much going on and it's just, oh my goodness. And I'm in my office, not in clinic. Patient has an urgent issue, so I use our encrypted texting, and I text McKenzie. I have no idea where she is or what she's doing. I just go, McKenzie, help. I'm not at the EHR. This patient has this question about bisphosphates with everything else. And I got this marvelous long answer very quickly. So I took you away from something. But you allowed me to coordinate care for a patient who needed it real time, because we had a relationship that we could trust each other. And I knew you had clinical knowledge I didn't have, and it would take me too long to figure out. And I will tell you that the patient was so appreciative because she also knows her, alternately McKenzie or Dr. Calhoun. And it's those relationships that are really the core of how we take care of our patients. And so it pleases me when I know that every team member has become a person and a part of that, and not just a name or a fax or some checkbox.
Well, it strikes me that there's some very similar themes coming through from both descriptions, how you've worked with McKenzie and also how Kieran and Paddy work together. And the things I'm hearing are understanding the clinical perspective and the pharmacist being there as a clinician rather than just a source of information or knowledge. Yes. The relationship, as in being able to have the knowledge that you can call on your colleague. And the other thing that strikes me is the immediacy, having that in real time rather than, as you, Kieran, said, having it an hour later when the meeting's over. Are they the main things that have helped towards this sort of collaborative working, or is there anything else that I'm missing?
I would say that they're the main things. The only thing I would add to that is also the reassurance that there's no howlers in your decision, and it is very reassuring when Paddy doesn't say no, you can't do that. That's because sometimes these decisions can backfire badly in terms of drug interaction or in terms of previous drug experiences, which Paddy has a knowledge of what's been tried before and failed. So that is also very reassuring when you're making clinical decisions.
And you mentioned earlier, before we started the podcast, about that reassurance actually manifests itself even in terms of, from an insurance perspective and making decisions, it actually gives you a sense of security that there's a second check almost.
Indeed.
Yeah. Okay. So, Bryan, you spoke yesterday about, just when Kieran brings it up, about the importance of medication errors. You had a statistics that you shared with us yesterday that implied planes falling out of the sky. Would you mind just sharing that with us?
Well, that sounds rather horrific.
It does, but it is rather horrific when you do.
747, 250,000.
That's right. Yeah, that one.
You remember.
Right. So, I guess I've taught somebody.
You've taught well.
Right, okay. Yeah, so there was a great article in The Lancet about 6 to 8 months ago now that looked at medical error in the United States health system. As I said yesterday, I'm not quite sure why we did not publish this from New England Journal or JAMA, and the folks in the UK were more interested in the problems in the US health system. But nevertheless, it was published in Lancet. And what they suggested was that medical error and medication error being the number one reason for medical error accounted for the number 3 reason for mortality in the United States health system.
Wow.
What that represented was, other than cardiovascular disease and cancer, we ourselves, our system, were the most efficient at killing people. Gosh. So if you don't look at that and don't recognize that there must be a call to do something, and the numbers that you were throwing out was, so 3 is the third reason for mortality. The other numbers were that, if to put this in a visible thing, that represents 4 747s falling out of the sky every day of every week, of every month, of every year. And I think that if that happened even a couple of days in a row in the United States, we would close all airports and stop and say, why is this happening? But because it doesn't happen collectively in one body, so there is one person in Miami who dies, there's one person in Dallas, and collectively that's 4 747s. But because they don't all die in the same hospital on the same day, we sort of shrug our shoulders and say, well, I guess that it was their time. That's what equates to 250,000 people per year in the United States.
My God, that's some statistic when you think about it collectively. And I suppose that is the difficulty when you don't see it collectively. It's throughout the system, and therefore that underlines the importance of what we're talking about and what you talked about, Kieran, going back to medication error, the idea that there's somebody else looking at that there for you. It must be very difficult as, even as a neuropsychiatrist, but as a medic, having to make decisions every day on people's therapy and reviewing, and then having other prescribers potentially in the mix sometimes as well. It must get very, I suppose, confusing in terms of medication.
I think our natural tendency is to play safe.
Okay.
So we develop a repertoire of medications that we're comfortable with.
Right.
And I think that has its comfort zone, but it also denies opportunity for other potential better solutions, for other choices. So I think we do need our perspective opened up by someone who has a broader knowledge, and a pharmacist there who would say, have you considered? I think is invaluable.
Okay, so this brings us back to the pharmacist being part of the clinician's environment. So Paddy, is this something, you said that all pharmacists are potentially capable of doing it, they have the information, they have the knowledge. Do they always do it? Do they play their part in the clinician's team, or do they serve as a source of information that's a little bit at distance?
At the moment, it's done as a source of information that's at a distance.
Okay.
And I think pharmacists have really good relationships with their local GPs. I do think that unfortunately, from a GP's perspective, they're probably hearing the pharmacist on the phone and they're going, oh my God, what have I done wrong now?
Okay, so
rather than it actually being an opportunity to actually sit down and actually say, well, actually, let's review the full totality of this person's medication. What just struck me there as you were talking to Kieran, our group of patients, because they're long-term psychiatric care, they have multiple comorbidities. They are often very heavy smokers, quite often really heavy caffeine consumers because of the drowsing effect of the chlorpromazines and the haloperidols over the years, and they tend to have sedentary lifestyles, and they develop diabetes later on, and all these different things are all happening at the same time. So they are quite complex in terms of their pharmacotherapy, and they're interesting from that point of view as well. But I do think there's an opportunity for pharmacists and GPs to start actually looking at structured medication reviews and what can be achieved with them. I'm involved in a project now through the HRB and RCSI where we are actually going to go out into GP practice and actually look at doing structured medication reviews with patients and GPs and looking at the patient's therapies and to see what sort of outcomes we can get that are positive for the patients by doing those reviews.
Okay, so that's where the pharmacist will be co-located almost with the GP, but just because there's co-located on their days where they're reviewing the therapies, is it?
It's just co-located, it's 1 day a week.
1 day a week, yeah.
So it's co-located for that day. It doesn't even need to be for a full day in our case because it's research. We will be co-located for the day. But long term, hopefully the model would be that you could actually do it across an hour or two of protected time that you both manage to set aside.
Super. Okay. Are there any other barriers to this happening? So yesterday, as part of the masterclass, there was a good discussion after we'd had the presentations about interprofessional collaboration. Some of the reasons why it was important. And I think there was widespread agreement that it was important and not necessarily just pharmacist GP, although that's what we're really focused on today. A wider, and as we've heard from the Bloomfield example, a much wider net of healthcare professionals. But we're focused primarily as a starting point on, well, that primary relationship between the prescriber and the pharmacist would be a good place to start. Listening to what was said yesterday, what are some of the barriers that stand in the way of us doing this more uniformly across the health sector?
You know, I really think proximity is a major issue.
Okay.
So one of the things that I've heard consistently, and Kieran, you put it so eloquently, like you use the word embolden, and I think that is really, really powerful. The idea that the difference between a relationship that is face-to-face and the power that comes with that. You know, in our current society where we are moving to so many things that are electronic in nature, there are things that just cannot be done and cannot be substituted, and education cannot be replaced without them being in a personal touch fashion. The reason that you guys are able to accomplish what you are doing is because there is a trust there. And that trust, I'm just not convinced, can be created through the telephone. There must be a personal relationship. Reid and I enjoy each other's families. We have a relationship beyond the professional. He asks repeatedly about my daughter and her interests. And so I think it is very hard to imagine this moving broadly from a distance. I'm not suggesting it's impossible, but I think without a relationship that is more personal, that it's very difficult to call up. The other thing I think that is really important is as soon as the relationship is defined by a phone call, then it creates a reactionary response. And at this point, maybe even a learned Pavlovian response that, as you suggested, Paddy, it's as soon as the GP hears that it is the pharmacist, because of what has happened historically in the past, that it is not oh, good, thank goodness he's calling, right? And so the opposite is if the pharmacist was there at the point of decision instead of after the decision is being made, and therefore having to react to something, that they could be more interactive at the point of the medicine being chosen, then that response wouldn't be what is currently.
Okay, it's interesting because what you remind me of is a study that was done in the UK, and I think it was entitled "Who Do You Think You Are?" And it looked at pharmacists' self-perceptions. And they self-perceived to be, they were actually quite derogatory about themselves. They said, I'm a bit nerdy, we're probably a little bit controlling. And they talked about how they found trying to interact with GPs. And they said, you know, it's terrible when you have to call a GP and tell him he's wrong. So what you try to do is you try to tell him he's wrong as nicely as possible so that he doesn't get offended. And it reminds me of, I don't know if you're aware, you will be aware, the Gottman principle of 5:1 positive interactions for every negative interaction, and the concept that in order to maintain a good relationship, having 5 positive interactions is really kind of what's needed in order to counteract the maybe more negatively toned conversation. If the only time we interact with somebody is to take up the phone to tell them that they're wrong, albeit we try to say it nicely, it's still a potentially negative interaction. Kieran, from your perspective, does any of that ring true, or am I just hypothesising beyond what we're talking about?
No, I mean, I was very struck by the need for the interpersonal touch, because I can see by Paddy's body language whether I'm heading up a cul-de-sac.
And that's without me having to hold his hand.
So it's very encouraging, because I can see whether he's really behind something or only humouring me by the body language. It's the eye-to-eye contact is very valuable, whereas the information down the phone tends to be factual, and you think to yourself, well, potentially I could have looked that up in the British National Formulary or so. It's cold. Paddy's information is go for it or not, and that's very valuable because it gives clinical impetus to the decision.
So it's the gut feel that he transmits, almost, where you kind of get a greater input rather above and beyond the knowledge. It's the experience coming through and the...
Oh, very much so, yeah. Okay. It's because I keep emphasising the clinical side of things. What you're in the room as a team, really, to try and toss the clinical issues around, it's very heartwarming to come to a consensus decision, and everyone is part of the solution, and that is very encouraging. Whether it's to tell a relative that you're stopping a medication that they thought was essential or not, when you get a consensus view with the pharmacist behind the decision, it's very reassuring. And
it occurs to me from what you said earlier, Reid, you can move once that relationship is established to maybe more remote contact. You have the relationship with McKenzie, and so therefore contacting her through your remote medium worked, but only because you had that other relationship built up. Would that be true?
Yeah, it allowed me to be comfortable sharing my uncertainty. And that's a really big part of this relationship, because the moment I'm able to say and believe and know that McKenzie and Bryan and Paddy, I'm quite sure, know so much more than I do about this aspect, it can actually take a burden off of me. I know a lot about it. I have my repertoire. I have the ability to look it up. But why should I do that when I have somebody else who can put in the clinical realm, and then I can do those things that I'm better trained to do that they're not? And so a big part of this, you asked earlier about the impediments, and I think a large part of them is we talked a lot yesterday about silos, and how we've got this fragmentation, and sometimes it's very overt, but a lot of times it's covert. And so going back to the co-located, you can have several practitioners from different disciplines in the same building, and you could still have very covert silos, because all you do is refer for a consultation in a box and no one ever gets together. And I think in order to get around those impediments, you do need top-down. Hopefully organizations can come together and agree on a process. I will tell you, in the States, that doesn't happen easy. There was a meeting we had just before this podcast that we didn't think could ever happen in the United States in terms of getting certain accreditation bodies, at least in the same room even. But top-down has to happen, and a key to that, and I'm really excited about your project, Paddy, because the outcomes measures do drive administrative decisions. We can't just say it's the right thing, it feels good, everybody loves it. You've got to give data. So we actually have to become better at at measuring what we do that works well, which is hard for individuals, because the other ways of getting through this while you're waiting for top-down is you need to find those champions, those people who are passionate about what they're doing, and find the bright spots of where something is working. And then you have to add that extra part of, okay, measure it. And that is sometimes actually the hardest extra part, because you've got people who are working above and beyond to do the right thing, and then to have to build in an appropriately very structured process to make sure that you can prove what you already know to be true, that this is good. But if we don't do that, the top-down changes are harder and the transformation slower.
And that actually brings us to a very nice point at which to think, how do we progress from here? Because there can often be a chicken and egg scenario of, do we wait for the policy or the memo or the structure to do this? Or do we do it in the hope of changing the policy? And that's where I suppose this discussion isn't venturing into how can we change policy, because that doesn't necessarily rest within our gift. But what we're looking at and hope to stimulate thinking for any listeners is, how can I, as a pharmacist in my day-to-day practice at the moment, start nudging the direction towards this? I think Paddy and Kieran are an exceptional example, along with their colleagues in Bloomfield, of how you can do it without waiting for the memo. You just go ahead and do it. And as we're coming close to the end, what I'd love to do is perhaps finish up with each of us providing a nugget of what we think somebody who's listening to this might be able to do in order to progress this on in their own realm, without waiting for the memo, without waiting for the policy. Hopefully that will come and we nudge it on in other agendas. But for somebody who is either working in their dispensary right now, or going back to it after a break, or going in tomorrow, what could they do? So I don't know who'd like to kick that off, but Reid, you...
I'm happy to start. I wanted to piggyback on something Bryan said before, and it's a suggestion I've made to people. So much of what we value as humans and what we are losing with new technology is relationships and the social connection. And so much of what we're talking about making changes is about respectful communication, knowing the person and not just the title. And so I would suggest for that pharmacist in the community to reach out to a GP and say, let's do lunch, let's do dinner. If you see them at a social event, sit down and say, let me buy you a drink, let's talk a little bit. And it doesn't have to be clinical. And it can start out with, I love your concept. I've heard it was 10-to-1 positives to negatives, but yeah.
Maybe that's where I'm going wrong.
I don't know. So start doing a little more. But, you could start out by just saying, I'd love to buy you a drink. I really respect what I see. You may not know me, but I see a lot of your prescriptions come through, and I really appreciate your patients say nice things about you. Now, please, that has to be sincere. But there's always something like that. And that is really a disarming way of beginning a conversation. But it's not just to become better clinicians. It really is to get to know the people in your community. Bryan talked yesterday about, every pharmacist has a community, every GP has a community, and many of us are taking care of the same communities. And so the moment we can say, we're in this together, you've got burdens, I've got burdens, let's see how we can help each other. And that can happen much better with social events than meetings or organizational sessions. And it's got to be out of the office.
Perfect. Okay. Who's next?
McKenzie. I really am not trying to just say the same thing again, but it has to start with the relationship building. And I know that we've said that a few times in the past few days, but the reason it works in every successful example throughout my training, as well as I believe that it works where, and that's not to my credit, it is to my team's credit. It's that we have the mutual respect. I'm on a group text message with several of the attending physicians I work with, and it's the same group text message that we talk about how often we wash our hair, and as well as complicated patients. And I don't mean to belittle the really important conversations that are happening about patients, but these people, it's like with Bryan and Reid talking about they care for each other's families, and my two Irish colleagues being able to talk about, joke around with each other about holding each other's hands. I mean, it really has to be that you have a personal relationship with all of the members of the team, and then keeping in mind that the second piece is keeping in mind that the patients come first. And so whatever that requires, if that requires all of us to check our egos at the door and say that we think that we can do a better job taking care of patients if we do that, then that's what has to happen.
Brilliant. Okay, Kieran.
Yeah, I'd agree with the personal relationship, because I think that once you trust each other's clinical judgment, it allows you to cut to the chase. In other words, what I found is that if you're reading a national formulary and you're looking at all of the pros and all of the side effects and the sheer list of the potentials, to be able to say to your colleague, what would you do and why? And they can sum it up and cut to the chase. And I think that's invaluable. And that's really, in my experience, what clinical medicine is about. Its ability to digest all the information and come to a decision. And to be able to do that with a colleague is very, very reassuring, and I think the patient benefits.
Brilliant. So it's building on relationships and actually then moving to the clinician relationship. So Paddy and Bryan, you're the two pharmacists left to give your opinion. I'm going to challenge you to, we know that relationships are important, but to your pharmacist colleagues out there, what other things might they do at this point? So Paddy?
Well, there are some funny things. You mentioned barriers, and a lot of what the difficulties that pharmacists have out there is some of the barriers. Sometimes they have their hands tied behind their back because they don't actually have the full picture of the patient in front of them. They don't have the original diagnosis often. But if they do manage to get the original diagnosis, they should record it and keep it. So the patient who's on sodium valproate for bipolar disorder, they need to note that it's for bipolar disorder. So when they see the letter coming back from the hospital in 3 years' time that says the patient suffers from epilepsy, they can actually go, actually, you're wrong. The hospital are after giving somebody an epilepsy label incorrectly. That does happen. And by the pharmacist actually having that clinical information and storing it and on their systems, they know what's going on. They know why the patient's being treated. Getting discharge letters from hospitals is vital because the doctor gets them, the pharmacist doesn't. They see the discharge prescription. By seeing the discharge letter, you know that the 3 changes to the medication regime are actually clinical decisions and not errors, because often they can be errors in transcription. So it's actually taking a little bit more time to look closer at the patient and build on those relationships with your local GPs, and if you can, start sitting down with them and eventually start talking about patients.
Okay, thank you. And Bryan, I'm going to give you the because you went last, you're going to have the greatest challenge. Paddy mentioned something that hasn't come up in the conversation, but actually is important to give reference to. Often we'll say we can't do this without a shared medication record, or we can't do this without a contract in order to give us the time. For somebody who's out there feeling a bit done onto and feeling that the conditions aren't ripe for all of this, what would your last word be to a pharmacist in terms of being proactive or trying to nudge this agenda along? Sorry to put you on the spot.
Revolutions do not require a memo. They don't happen from the top. They require a few people to realize that there are a few other people who agree with what they think and how they need to proceed. So finding a few like-minded people who say, I feel your pain, and I think that we can do something together. And by creating a small group of like-minded people, it's amazing the amount of change that can occur. I think that it's so easy in our busy lives, in our overwhelmed lives, in our over-scheduled lives, that we not take time and make time for the things that are of great value and great importance. I can't think of many things that are more important to us as a society to take care of everyone. If this can be taken at that level I think we all get so busy that the minute by minute problems can drown out the larger picture that must be required for change. And the reason this wonderful example here is able to be done is because someone recognizes I have to go above and beyond. And so it's in all of us. It's just that there are an awful lot of employees who have been treated as such for a very long time and therefore kind of changed their thinking that I'm not capable of making change. And so I would, as loudly as I can, scream from the top of the mountain, that's not true, and find the others who agree and align, get your pitchforks ready, and go burn something.
Wow. Okay. Well, there's a lovely rebel call to finish us up. I think the key message is find the bright spots.
In a good way.
In a good way. Those burning torches are the bright spots. Align together and make a difference where you can. And I think it's true. The sentiment is if we do that, although it would be lovely if the path was smooth, once we start to come together, hopefully we'll be able to make the new path into how we want healthcare to look in the future. I have to say, I've thoroughly enjoyed the discussion. I love the positive, forward-looking nature of it. I would love to see more of this type of discussion within all professions. I realise we've only just scratched the surface of how we might work together, that there's lots more professions that should be involved in this conversation. But I think it has been a wonderful place to start the discussion, and hopefully we can build on it and have many more. So thank you to each of you as panellists, and I'm looking forward to continuing the conversation into the future.